Good afternoon, everyone. Welcome to the session. My name is Delany-Moretlwe from the University of the Witwatersrand in Johannesburg, South Africa. And on behalf of myself and my co-chair, Dr. Prapan Panupak, we want to welcome you to this session, Pedal to the Metal, Accelerating the Cascade. We have a great lineup of presentations reflecting diversity in terms of geography and population, and really kind of some inspiring and thought-provoking ideas around how we achieve 90-90-90 targets for the treatment cascade. The format of the session will be all presenters will present for 10 minutes and have 5 minutes for Q&A. And if there are still questions afterwards, we would encourage you to meet with the speakers after the session. So I'm going to introduce the first three speakers, and then I will hand over to Dr. Panupak, who will introduce the last three speakers and then sum up the session. And hopefully we will get through this by 6 p.m. this evening. So I'd like to start by introducing our first speaker. Daniel Williams is a health scientist for the CDC Division of Global Health and TB, and his presentation is entitled Rapid Antiretroviral Initiation and Index Client Testing Outcomes of Commlink, a community-based HIV testing, mobile HIV care, and peer-delivered linkage case management program, Swaziland 2017. Over to you, Daniel.
Good afternoon, everyone. It's an absolute pleasure to be here to be speaking on behalf of my fellow co-authors about the Commlink Program. My fellow co-authors being from the Eswatini Ministry of Health, Population Services International, and the U.S. Centers for Disease Control and Prevention. I'd like to start off with a little background and context. Eswatini has a population of approximately 1.1 million people, with approximately 200,000 living with HIV 15 years of age or older. It has an HIV prevalence of 27% among PL-HIV 15 years of age and older. And there have been significant challenges linking PL-HIV diagnosed in community settings to HIV care. There were two recent studies in Eswatini with approximately 1,500 participants that found that only 17 to 34% enrolled in care within 6 months of their diagnosis in those community settings, with young adults young adults at higher risk for delayed linkages. So the Commlink program, the Commlink Linkage Case Management Program, was developed with the goal to link to care 90% or more community diagnosed PL-HIV by providing the full package of services that are recommended by the International Association of Physicians in AIDS Care, the U.S. Centers for Disease Control and Prevention, and the World Health Organization. And it's also informed by experiences and outcomes of the Bukoba, Tanzania Linkage to Case Management Program, and Oscar Rabiago has a poster on that program that's on display today. All right, so the recommended services that are offered by the Commlink program are the integration of HIV testing and counseling with HIV care services, on-site CD4 testing with same-day results, transport or escort to an HIV care facility for a client's first visit, and then also, along with that, treatment navigation services, linkage case management, telephone follow-up calls and text messaging, HIV-positive paraprofessionals that deliver linkage services, provision of counseling on the benefits of care, supported disclosure and assessment and resolution of barriers to care, and finally, the tracking and evaluation of enrollment and care outcomes. All right. So the implementation of these services starts at community-based HTS outreaches. Identified HIV positives are introduced to an HIV-positive expert client counselor that provides post-test counseling and screens for eligibility. Eligible clients are those that are newly diagnosed or previously diagnosed and have been out of care for 3 months or more and have been referred to a facility that was within the Commlink operating area. If eligible and consenting, the first of 3 required face-to-face case management sessions between the EC and the client is conducted right there on site. Also during that visit, during that first session, clients are escorted to an on-site mobile clinic to see a Commlink nurse and receive baseline HIV clinical services. But please note that ART is not being initiated from the mobile unit. The next two required face-to-face sessions are to provide psychosocial support, discuss and attempt to resolve barriers to care, encourage disclosure when and where appropriate, and provide index client testing. And additional face-to-face sessions can be conducted depending on the needs of the client. Clients are encouraged to enroll in care as early as the first encounter or at any time during the case management period. Expert clients will escort or meet the client at the facility to provide treatment navigation to make clients more comfortable and knowledgeable in order to access HIV care on their own in the future on subsequent visits. Phone contact is maintained with clients throughout the case management period, and cases are closed when the client receives their second ART refill from that facility. Okay, a closer look at the operations of the program. Commlink is implemented by Population Services International in very close collaboration with the Eswatini Ministry of Health and the CDC. Phase 1 of the program ran from June 2015 through March 2017 with a team of with 2 mobile unit teams of 3 expert client counselors and 1 nurse each that operated in select areas of the Manzini and Ho-Ho regions. Of 651 participants in Phase 1, 98% enrolled in facility-based HIV care, and 83% were initiated on ART. So more specifically, that's 66% during the period of initiation at CD4 less than 350, 81% at or below 500, and then 96% during the test and start era. Phase 2 of the program ran from April 2017 through March 2018. And during that period, the scale of the program was doubled, and the operating area was expanded to include all of Manzini, Ho-Ho, and Lubombo regions. And methodology was modified to include the associates of clients as participants in index client testing. Associates are defined by the program as persons other than partners or family members who might have defaulted from care or who might otherwise benefit from HTS. And that includes the client's friends, their neighbors, and their coworkers, as example. This is a program form that guides expert clients to elicit from their clients their sexual partners, family, and associates that really lays the groundwork for conducting index client testing during the case management period. All right, Phase 2 outcomes. There were 709 positives identified during Phase 2. 99% were screened for eligibility. 85% were eligible to receive linkage services. 97% consented to participate. And a total of 480 were available for analysis. Okay, so this table looks at enrollment in care, ART initiation, and partner and family member testing and associate testing outcomes. 97% of cases enrolled in HIV care. 96% were initiated on ART. 73% were initiated on ART within 7 days of their diagnosis. 97% of those initiated on ART returned to receive their first ART refill. And 43% had 1 or more partners, family members, or associates tested. All of these outcomes, if you look at the disaggregates, all of these outcomes are similar across age and sex groups, though a larger percentage of female clients had 1 or more partners, family members, or associates tested. Okay, this table looks at PFAs, partners, families, and associates, that were tested through the program. There were a total of 294 tested, which were predominantly male and older. 59% tested positive, 25% newly diagnosed, 35% previously diagnosed and out of care. 52 partners were tested, and these were mostly male and older. 62% tested positive, with 25% of the total partners tested were newly diagnosed, 37% previously diagnosed and out of care. 124 family members were tested, and they were predominantly female. 49% tested positive, 21% newly diagnosed, and 28% were previously diagnosed out of care. And finally, there were a total of 118 associates tested. There was an even split between males and females among this group, and they were predominantly older. And you can see that 68% tested positive, 25% newly diagnosed, and 42% were previously diagnosed and out of care. Okay. So there were a total of 166 eligible clients identified through index client testing, and 99% of those consented to and chose to participate in the program, which represents 28% of all Commlink cases during phase 2. Of 144 closed cases that were available for analysis at the time, 90% enrolled in HIV care in a median of 2 days, and 90% were initiated on ART in a median of 2 days. All right, let's take a look at limitations, conclusions, and next steps. Obviously, there were limitations to the program. Commlink consent rates are not perfect, and enrollment and care outcomes are unknown among non-participants. Although most clients return for at least one ARV refill, longer-term retention in ART care is yet unknown. And startup for Commlink, the startup costs for Commlink are high, driven largely by the procurement of the mobile units that the nurses use on site. Substitution of mobile units for portable tents can reduce costs and may be just as efficient. So, in conclusion, we found that providing the package of recommended peer-delivered case management services achieved near universal ART initiation among PL-HIV diagnosed in community settings, including men and young adults. Integration of index client testing as part of linkage case management was reasonably effective in testing and identifying PL-HIV, but requires improvement in terms of testing partners. Index client testing that targets partners, family members, and associates was important for case finding. Like I said, it accounted for 28% of all Commlink cases in that phase. And finally, providing index client testing services to associates was effective and may be a particularly important strategy to help identify and return previously diagnosed PL-HIV back into HIV care. Oops, what happened there? Sorry about that. Okay, next steps for the program include a cost-effectiveness study in 2018 and 2019 to assess incremental costs in enrolling and retaining clients in ART care, compared with non-linkage case management cohorts. And currently underway is a national scale-up of the program as part of PEPFAR's ARROWS initiative in Swaziland. And to close, I'd like to thank PSI's dedicated, absolutely amazing, phenomenal Commlink staff and the Eswatini Ministry of Health for its continued support, many of which of both are here in the audience today. So thank you.
Thanks very much, Daniel. This paper is now open for questions. Perhaps while people are gathering their thoughts, I can ask you a question. I noticed that, especially given your earlier comment that adolescents had been quite hard to reach, that they seem to do quite well in this program. What do you think are some of the things that appeal to young people?
I would attribute that to PSI's strategies for conducting or for identifying locations where they conduct their outreaches and how they do community mobilization that really bring them out from the community they're in and run them through HTS services through the mobile unit and then into the program.
Thanks. And then perhaps another question was really, I think the index part or the index case finding is a very interesting strategy. Did you encounter any barriers in terms of acceptability or stigma or, kind of negative social outcomes?
Negative social outcomes in terms of like adverse events related to index client testing?
Yeah, I mean, kind of in some ways you're asking people to identify or refer people, and did that have any social consequences?
There were a couple of adverse events here and there, but honestly, the expert clients that PSI uses they use a variety of strategies to kind of get around that. So if, for example, a client is not comfortable with disclosure, they can get the contact information from the client and set up an anonymous testing of, say, that community or household, so to kind of avoid the connection between the client and the person tested through them.
Okay. Yeah. Thank you very much. Mm-hmm. Oh, sorry. There's a question at mic number 3.
Karen Beckerman, New York City. Were you able to offer a PrEP to uninfected sexual partners?
No, that hasn't been a strategy employed by the program yet, but it definitely has potential.
Because it seems that the case finding, you get 100% case finding. Either you find an uninfected person or an exposed infected or exposed uninfected.
Yeah, that's true. We do obviously find uninfected. So yeah, that would be a very good strategy.
Thanks very much.
Thank you.
Okay, well, now I'll move on to the third presentation of the session. Dr. Pitch Sikal is a program officer at the Thai Red Cross AIDS Research Center in Bangkok, Thailand, and his presentation is entitled Same-Day ART Initiation in HIV STI Testing Center in Bangkok, Thailand, Initial Results from Implementation Research.
Good afternoon, ladies and gentlemen. If I appear to be nervous, that's because my boss is sitting right next to me right there. I'm Pitch Sikal, and on behalf of the Thai Red Cross AIDS Research Center, I'd like to express my deepest gratitude and appreciation to all persons living with HIV. Your dedication, your passion, your leadership, and your sacrifice have guided us into the future where ending AIDS is a possibility. We are proud to be working with you, and we are honored to be working for you. Thank you. So today I'll be presenting the initial data from same-day ART service using the initiation hub model at the Thai Red Cross Anonymous Clinic in Bangkok, Thailand. I'm standing on shoulders of the many, many talented people who have built it and cultivated this program and made it to be what it is today. And this project is being funded by USAID Linkages Program. So here's an outline of my talk, give a brief synopsis of the HIV treatment in Thailand, as well as the barriers that deter ART uptake, followed by the design of our ART initiation hub model and the results that we have from it thus far. I'll then conclude my talk with the challenges that we face and the next steps for us. So Thailand has adopted UNAIDS 90-90-90 goals and make it the nation's strategy to end AIDS by 2030. However, our performance is quite subpar, especially around the second and third 90s. Focusing on Bangkok, the capital and most populous city in the country, only 57% of those who know their HIV positive status are on treatment, and of these, only 79% are virally suppressed. The national median CD4 at diagnosis is around 160, which shows that the majority of these people are being diagnosed quite late. And once they're diagnosed, several factors contribute to this delay of treatment initiation. The waiting time to get the essential lab bags is quite critical, as many of these facilities don't have same-day HIV results, and it could take up to 4 weeks for the CD4 count to come back. Additionally, many of the hospitals do believe in having multiple preparatory visits before starting treatment, and oftentimes doctors refuse to start ART among those with high CD4 count due to a preconception that these people still perceive themselves to be healthy, and therefore their ART adherence would be poor. And lastly, locations matter. Many of the clients don't like to go to their assigned hospital covered by their health benefit scheme because they know a lot of people there and they want to conceal their HIV positive status. And therefore, the Thai Red Cross Anonymous Clinic began to offer same-day ART service, hoping to increase ART uptake. So in this presentation, I will describe the same-day ART initiation hub model, assess the feasibility of the model, and examine if same-day ART service increase the ART uptake and viral suppression. And here are the primary outcomes. From the model itself, we wanted to look at the acceptability, clinical characteristic, time period of ART initiation, linkage to care, viral suppression. We also wanted to compare ART uptake and viral suppression with the historical data from the Anonymous Clinic. The data were from February 2015 to April 2017, where the universal ART guideline was in place and the drug regimen used was identical to what we currently have. So a little bit about the clinic. The Anonymous Clinic was established in 1991, the year I was born. It was the first in Asia to offer anonymous HIV and STI testing. And just to give you the capacity of this, how the clinic operates, last year we had about 35,000 people who came and got tested for HIV. And among these, about 7 to 8% tested positive, but we are not a hospital. We don't have many of the equipments that you normally find in the hospital, like an X-ray machine. And all of our clients are outpatients. So if the clients are presented with symptoms beyond the scope of STI, we refer them out for further investigation. And we can't do long-term monitoring unless the clients choose to pay for the services themselves. So this element helps us shape the eligibility criteria for us for the same-day ART service. The clients have to be willing to start ART, they must be ART naive, and they have to be able to come back for follow-up visits. And there must be no indicative symptoms of tuberculosis, of cryptococcal meningitis, or really any other serious opportunistic infections that may require hospital admission due to ART-related iris. So if the clients are presented with symptoms indicative of these illnesses, we will delay the treatment and refer them out to be investigated further. Our algorithm is based on the Thailand national guidelines. So the drug that we used is the first-line drug regimen recommended by the guideline, which is FTC, TDF, and FL variants. And these are all the baseline tests that we order. One important thing to note is that not all the results from these baseline tests are available during the first visit, and that is okay for most cases. The two things that we must know before we initiate treatment are the confirmatory anti-HIV test and the results from chest X-ray. This picture illustrates the ART initiation hub model at the anonymous clinic. Our clients could be from walk-in, or they could be from referral from key population-led health service community sites. And these are CBOs whose services are being provided by the key population lay providers. So during the first visit, after being notified of their HIV positive status, they will receive post-test counseling, psychosocial and emotional readiness assessment, baseline blood collection and chest X-ray, medical history, and physical examination. And if there's no medical contraindication, they will be prescribed ART for 2 weeks and asked to come back for the follow-up visits. And during this time, before the follow-up visits, our team will initiate the linkage to care process. And one important thing is that if there's an anomaly in the baseline lab test, we will ask them to come back before the follow-up visit for an intervention. So during the follow-up visits, the clients will be notified of their baseline lab results and will be assessed of their potential side effects related to ART and ART adherence. And if there's no additional concern, the clients will be prescribed ART for 2 months. And lastly, our team will accompany them to the preferred long-term ART continuation site, either at their eligible hospital or the transferred hospital as a warm hands-off. And our team will be in touch with the clients 1, 3, 6, and 12 months after ART initiation. So from July 2017 to April 2018, 1,589 people tested positive at the clinic, and among these, the acceptability of same-day ART service was at 90.4%. Higher acceptability was observed among the newly diagnosed cases, which was at 94.4% when compared to the re-engaged cases, and these are people who already knew their HIV positive status. And stratified by the populations, transgender women had the highest acceptability, which was at 94.1%, followed by MSM at 92.2%, and the acceptability was lowest among those from the heterosexual population. And among those who accepted, 58.1% were newly diagnosed cases, 70.4% were MSM, 25.1% were those from the heterosexual population, and 4.5% were transgender women. The median age at the first visit for us was at 28.6 years old. The median CD4 at the first visit was 299 cells per cubic millimeter, which is quite higher than that of the national median CD4, which was at 160. 79.4% of the clients who accepted the service were able to start ART during the first visit, and we categorize this group as same-day ART initiation. Several factors contributed to the delay of treatment, including coming in late in the afternoon, surpassing the lab's operating hours. This figure shows the cumulative incidence of ART initiation between the historical data denoted here as standard care of the clients and with the clients from same-day ART, which was determined to be statistically different. And when compared to the standard care, same-day ART clients were 3.9 times more likely to start ART after HIV diagnosis. After ART initiation, we were able to refer 89.64% of the clients to long-term ART site with a median time of referral at 56 days. And this was assessed among those who have reached 75 days after ART initiation. Among those who were not successfully referred, 4 stopped ART, and 2 of whom were stopped by a doctor due to ART-related illnesses. And 4 clients who have been on ART for 3 months, retention was at 92.2%, 0.7% discontinued ART, 6.4% were lost to follow-up, and 0.3% with death. Retention 6 months after ART initiation was at 91%, 0.5% were discontinued ART, 8.5% were lost to follow-up. Viral load testing was conducted at long-term ART sites, so it wasn't up to us when to order the test. But when we did this analysis, 181 clients were tested for viral load, and of these, 93.9% were virally suppressed, and the median time from ART initiation to viral load suppression was 162.5 days. This figure demonstrates the cumulative incidence of viral load suppression comparing same-day ART service to the standard care, which was determined to be statistically different. Additionally, the Cox proportional hazards determined that same-day ART clients were 2.2 times more likely to be virally suppressed when compared to the standard care. So relatively speaking, same-day ART is quite labor-intensive when compared to what has traditionally been done in Thailand, requiring multiple staff to prepare the clients for ART and a redesign of how how HIV care is delivered, which means that many of the facilities that don't have these essential labs readily available may need to refer their cases to an initiation facility, creating this sort of like initiation referral network. And having the point of care test will be very beneficial to same-day ART, but we need to make sure that these tests are affordable across all sites. I think a lot of doctors are still concerned with the client readiness and the clinical safety, but I think our data have shown that it is safe and feasible to do same-day treatment. And lastly, the long-term data, the time point of where the long-term data was collected entirely depends on the long-term referral site, which means that the numbers that we see here may not depict the actuality. Right now, 13 hospitals in 5 provinces around the country have taken up our initiative, and we are working very closely with them to redesign the algorithm in HIV care delivery and setting up the data collection that is systematic. We have both public and private hospitals ranging in sizes. We have both specialist and non-specialist facilities, and this will help us determine different models for same-day ART, increasing the feasibility and applicability to different settings. And once more people are on ART, we need a new system that supports and lessens the traditional facility healthcare, like having the key population-led differentiated service delivery. And we need more data that is systematic and can be measured precisely and consistently to show the real-world implications of same-day ART. And here are my acknowledgement. I would like to give a special thanks to Dr. Dan Hafler at UCSF for giving us the rapid protocol. And again, this project is being funded by USAID Linkages Program. Thank you very much.
Thanks very much. This presentation is now open for questions. So I think that everyone is overwhelmed by how impressive your outcomes have been. And you talk about how it's a labor-intensive approach. What do you think are going to be, or what will be some of the modifications you'll make as you scale up? Are there any things you might do differently, or any things that you kind of will have to adjust as you go to scale?
I think it is labor-intensive because for us, we integrate the community health workers in our cascade, in our care. I mean, I didn't have enough time to go into detail. And I think this is worth investing for the good outcome that you just see. I think it is feasible for the government to see that it is important to include the key population members, because we do have key population members who are MSM, transgender women, and persons living with HIV working with us, helping with the retention and linking people to care, because it creates that trusting and more relatable relationship.
Thanks. I had another question, and it might be that I missed it, but it seems that there are a proportion of people that you identify that were previously in care that have dropped out. Mm-hmm. And what do you think the model does to re-engage them? What's sort of different that overcomes the barriers that may have led to drop out?
Right. So like I said, I think there are several factors. So I think you meant the re-engaged cases who already know their HIV positive status but are ART naive. I think these people, it was really, there was a survey coming out assessing people who were HIV positive but did not get on treatment, and 50% of them reported that the health insurance being the main barrier. And I think in the setting in Bangkok, we have a lot of people who move to Bangkok for work, but their health insurance is still based in their provinces, home provinces. So they just didn't know how to go about changing or even know where to go for ART access. So I think having this entry point of getting them into the care cascade, open up the channel and open up their opportunity for them to walk in and say, I want to be on treatment.
Thanks. Thanks very much for your presentation. Oh, sorry, there's a question at mic number 3.
Sorry, Simon Collins from London. So it's really just to say the data are really encouraging. It's amazing to see the program you're putting together. And just when I thought it couldn't get any better, you said that you include a peer support worker. And I think that's a really important way to make people feel, to break down the medical barriers. So it's an amazing project. Thank you.
Yeah, like I said, I didn't have enough time to go into this, but for this program, we actually created a new position called the navigator. We didn't have to have it. We used not to have it. But the navigators is the key essential for our success for this program. And again, all of them were from the key population.
So even better, you're paying a community worker. That's great.
Yeah, thank you.
Okay, thank you very much. So it's my honor to continue this second half of this session here. My name is Prapan Panupak. I'm the director of the Thai Red Cross AIDS Research Center. And I would like to continue further about this more accelerated or rapid treatment and outcome here. So the next speaker will be Dr. Delany-Moretlwe. She's from Ministry of Public Health in Botswana. Her topic will be on fast-track ART initiation in Botswana. It's associated with high rates of ART initiation, high rates of retention, and increased viral suppressions. Please.
Thank you, Chairs, and thank you to the organizers of this conference for giving us the opportunity to share with you our data. On behalf of the YATSIA team, I'm going to present on the high retention in care and virological suppression after fast-track ART initiation in the Botswana Combination Prevention Project, BCPP. Despite high ART coverage, HIV incidence in Botswana remain high at 1.35%. And this is despite Botswana being close to achieve 1990 coverage targets. Continued high incidence of HIV transmission may be the results of insufficient scale, coverage, and quality of proven intervention methods. PCPP is a cluster randomized community trial evaluating the impact of HIV incidence of combination prevention package, including rapid scale-up of HIV, of HTC and linkage to care services, rapid scale-up of universal ART, and rapid scale-up of retention in care and adherence intervention. Fast-track ART initiation addresses the second UNAIDS 90. It is not known whether fast-track ART initiation has any significant effects on an individual's HIV treatment outcomes, and also may also have a population-level effects by resulting in more rapid virologic suppression. BCPP implemented Universal Test and Treat, UTT, and fast-track ART initiation with enhanced counseling and ART offered at the first clinic visit following the national launch of UTT in June 2016. Prior UTT fast-track, Botswana national guidelines recommended baseline blood tests and adherence counseling before ART initiation, requiring minimum of 2 to 3 visits. Here we'll compare outcome pre and post fast-track ART. BCPP operated in 30 communities, 15 being intervention and 15 control. This sub-analysis focused on the 15 intervention communities and evaluates, 1, the cohort of patients identified through enhanced BCPP testing and linkage activities between October 2013 and May 2016, initiating ART according to the modified national guidelines and visit schedule. And 2, patients initiating ART following UTT introduction, 1st June 2016 to 31st December 2017. During this period, all participants with positive HIV verification tests were immediately referred for ART initiation. The proportion of patients initiating ART, the timing of ART initiation, and the treatment outcome were assessed. 61,641 community residents were assessed. And of these, 13,251, which makes 21%, were HIV positive. Of the HIV positive, 27% were not on treatment, and all were referred to the ART clinic. 93% linked, and of those who linked, 2,342 were linked pre-fast track, and 82% of them were eligible according to the national guidelines, which was CD4 less than 350, WHO stage 3 and 4, and later to WHO stage CD4 count less than 500, or additional study criteria of viral load more than 10,000 qubits. Median age was 36 in the pre-fast track and 32 in the fast track. 62% were females in the pre-fast track and 56 in the fast track. The median baseline was more or less the same, 334 in the pre-fast track and 349 in the fast track. 52% of those who were newly diagnosed in the pre-fast track and 65 in the fast track. In both groups, few percent have been exposed to ART before, either during the PMTCT or those who were initiated by the defaulted. The cumulative probability of initiating ART within 1 year was 83% in the pre-fast track group and 85% in the fast track group. Now looking at the timing from linkage to ART initiation, in those who initiated on the first day, day 1, 7% initiated in the pre-fast track and 60% in the fast track. Within a week, 16% had been initiated in the pre-fast track and 73% in the fast track. And by the end of the month, 52% were initiated during the pre-fast track and 87% during the fast track. And the graph just shows the rapid level of ART within the week to a month in the fast track group. Just to assess the outcome of those who were initiated during the fast track, we assessed the retention in care and viral suppression. And this was really restricted for those who were initiated for more than 6 months. 1,844 were initiated for 6 months and more during the pre-fast track, 94 were retained in care, and 98% were virologically suppressed. And we found similar results in the fast track group, with 816 being initiated for 6 months or more, 93% were retained on treatment, and 99% were virologically suppressed. If we were to make that extremely conservative assumption that those that we didn't have the viral load results, test results were not suppressed. In the pre-fast track, 85.6 who were retained on ART had viral load and were suppressed, and in the fast track was 85%. And we further went ahead and looked at the subset of the fast track, those who were initiated on the first day. And out of 503, 93% were retained on treatment and 98 were virally suppressed. And again, if we were to make that assumption that those who didn't have the viral load test results were not suppressed, 89.1 were retained, who were retained on treatment had viral load and were suppressed. Time from linkage to first viral suppression was significantly shorter following introduction of the fast-track ART. Median days from linkage to suppression was 210 in the pre-fast track and 104 in the fast track. Fast-track ART was safe and well tolerated. We had 1.32% of deaths in the year following the linkage pre-fast track, and 0.9 in the year following the linkage fast track with a p-value of 0.3. 1.4% patients initiating ART within the first week during the fast track period had an abnormal creatinine clearance, 6 of whom were on ART at 1 year and 3 whom died. In conclusion, fast-track ART was acceptable and feasible and led to increased rates of ART initiation and markedly reduced the time from initial clinic visit to treatment start. Rates of retention in care at 1 year were as high in fast-track as fast-track. Virological suppression rates at 12 months post-fast-track ART initiation were very high. Virological suppression was achieved twice as fast in fast track, which may have individual and population-level transmission benefits. These findings demonstrate that fast-track ART initiation does not lead to lower retention in care or lower rates of virological suppression at 1 year. To summarize it all, fast-track ART led to equivalent or more or improved rates of ART initiation, retention in care, virological suppression compared to prior practice, and could help ART programs in Africa reach the ambitious UNA's 1990 targets. And I acknowledge all the partners that participated. Thank you.
Okay, thank you very much. Now open for question. The fast-track approach, it seems to me that it doesn't benefit the patients by themselves, but it benefits society or community in terms of more rapid viral suppressions. Is that correct? I mean, I have not seen any data which you showed it's the same as in terms of pre-fast track and fast track. In terms of viral suppression, retention, and so on and so forth, they are almost the same, except in the fast track group, you have faster rate of viral suppression, which may benefit others, but may not benefit the patient themselves. Is that correct? Is that my understanding correct?
Indirectly, it is benefiting because they are starting early and they are getting treatment early. But really, what we wanted to show was the fear that the people had, that these people are not properly prepared to start the treatment. They are not going to adhere to treatment. They are not going to stay on treatment. They are not going to be virologically suppressed. So this was like, really, it is the same, whether they were prepared for 3 months or they were started on the same day. And of course, the treatment for their own health, the fact that they start treatment earlier, so that also it will work on their own health. They become quickly virally suppressed and improve their immunity.
What are the important factors that make Botswana can implement this as compared to other countries in the region? What are the important factors that make your country can implement this fast track approach so that you can teach other countries around?
Yes, I think one, Botswana as a country, really we had a lot of support, political support, so that the environment, when we changed from one to another, we did have a support, even all that political support, and a lot of education, because now we're testing at home. We're starting our adherence counseling from home. By the time they come to the facilities, they were ready to receive the treatment.
Will South Africa do the same thing?
Well, I don't think I can speak on behalf of the National Department of Health, but certainly I think some of the things that we've heard today are going to be incredibly important for other countries in the region.
Thank you. Microphone number 4.
Yeah, thank you so much for your great presentation. I just want some clarity in terms of the term for virological suppression. There's a big difference between the pre-fast track and the fast track. How were you doing the viral load in terms of, was it based on a certain guideline? How did you calculate the median for those two different groups? Yeah, how is the viral load done? Was there any changes after the fast track guideline just to get an idea of how you calculated that median to virology suppression.
Because during the fast track, we had systems in place really to make sure that we track and trace our patients, that they come back to the facilities for us to be able to perform the viral load, or in fact that they try to be out of the treatment for some few days, we'll bring them quickly. So we had systems in place, unlike the standard of care that we had initially, because during the pre-fast track, we're following more of the national guidelines and the schedules.
Okay, the last question from microphone 4 before we move on. Yeah.
Thank you for the presentation. My question is about the regimens used and if they are the same in the two tracks, the drugs used for ART initiation.
Can you come up again?
If the regimens used for ART initiation are the same in the two tracks, or there is any difference in the drugs used that can explain the earlier virological response?
Yes, when the UTT was launched in June 2016, this is the time also we launched DTG in Botswana. So the patients that were on the first track were receiving DTG as our first line, compared to the pre-fast track where we were using the efavirenz-based.
So do you think that the early virological response is associated with the change of treatment, not with the rest of intervention? Or is a mix, or there is another adjustment for this effect?
That is something that we haven't yet looked at, so I cannot say that for now, but it's something that to look at.
Okay, thank you very much. Yeah. The next presenter is Dr. Paul Wakasa from the Center for Health Solutions, Kenya. His paper will be on towards the third 90 factors that associated with adolescent antiretroviral adherence and viral suppression. Please.
Thank you for Professor Panupak, and thanks for the organizers of the conference for giving us an opportunity to share the work we're doing in Kenya, in Siaya County. So first, to acknowledge support from CDC. This work, the results I'm presenting are funded by CDC, and to also provide the CDC authorship disclaimer. My presentation will first start with the background, the methods, results, conclusions, limitations, recommendations, and finally acknowledgement. So adolescents are at the center of the global HIV epidemic. Globally, AIDS-related deaths declined by about 32% in the other age groups, but increased by up to 50% among adolescents. The adolescent HIV epidemic also continues to be fueled as children who are who got HIV through vertical transmission transition to adolescence. And sub-Saharan Africa is disproportionately affected, with 85% of the burden, particularly in Southern and Eastern African countries. In Kenya, it's estimated that about a third of new HIV infections are among adolescents and youth. Adolescence, as we are aware, is associated with unique psychosocial and health changes and needs. Some examples are needs for autonomy, risk-taking behavior, peer influence that could affect their management of adolescents living with HIV. Suboptimal adherence and viral suppression are more likely among adolescents, affecting future treatment options. So we sought to investigate predictors of adherence and viral suppression among adolescents living with HIV in Siaya County, which is among 5 counties with the highest burden of HIV in Kenya. We did a retrospective cohort analysis of 2,814 adolescents who are receiving care in 119 health facilities between the year 2000 and 2017. And we evaluated various variables, including age, sex, the sub-county, ART regimen, viral loads, self-reported adherence, frequency of clinic visits, the caregiver factors such as their self-reported adherence, HIV status, attendance of support groups, and whether they had a stable caregiver. We conducted bivariate analysis and multiple logistic regression analysis to evaluate outcomes and reported odds ratios and at 95% confidence intervals. Of the 2,814 adolescents, slightly over half were female. Majority were from two sub-counties, Game and Bondo, and the mean age was 13.3 years. Self-reported adherence was a majority finding for most of these adolescents at 78.8%, and those who had fair and poor adherence self-reports were 14 and 7.2% respectively. Over half, about 61% of the adolescents had achieved viral suppression, defined as viral copies less than 1,000. So we noticed the interesting dichotomy, the interesting dissonance between the self-reported adherence at 78.8%, and suppression rates at 61.6%. Among caregivers, about more than half attended support groups, half were HIV infected, and of those, 99% were on ART, and 88% reported good adherence. So in bivariate analysis, a couple of factors that became interesting and were statistically significant for adherence were, of course, the number of copies of the viral load, good reported adherence among the caregivers, and the attendance of support group among caregivers, as well as frequency of clinic visits. And for viral suppression, also by bivariate analysis, the statistically significant findings were related to gender, particularly the female gender, those who were on second-line or third-line regimens, and tenofovir-based ART regimens as a core regimen, and who had self-reported good adherence, as well as attendance of support groups by the caregivers and frequency of clinic visits. But now in the model, we found a couple of factors that were important for the adherence model that were statistically significant. And these included the region, the sub-region, which was a sub-county, particularly in this case Siaya and Ugunja, the most current viral load measure, especially for those who had viral suppression. Of course, it would be related to adherence, a good adherence, as well as good adherence for the caregiver, 9 times higher odds of adherence with the adolescents, and clinic visits more than 2 months at about 3 times prediction of adherence for the adolescent. For the viral suppression model, a couple of factors were statistically significant. This included the region, and in this case, the sub-regions of Rarieda, particularly at 1.9% higher odds, 1.9 times higher odds. The regimen, particularly those who are on a tenofovir-based regimen or those who had a second or third line regimen. And clinic visits interval of 2 months and above. So in conclusion, we found that good adherence among adolescents was associated with viral suppression and caregiver, good adherence reported among the caregivers and the region, as well as frequency of clinic visits. And for viral suppression, this was among adolescents was associated with good self-reported adherence, clinic visit intervals of 2 months or more, region and regimen type, and whether it was a second or third line regimen. Of course, we acknowledge limitations in this analysis because we use self-reported adherence, which is commonly the evaluation method for adherence in implementation settings. We know that this is a limitation because this is an inferior assessment to gold standard for adherence. And we also use cross-sectional viral load results, therefore could not measure effect over time. And we did not adjust for the duration on ART or mode of HIV transmission. And so we recommend prospective evaluation of the effects of these factors over time to inform implementation strategies on the ground. I acknowledge all the participating adolescents, the health facilities in Siaya County, the Department of Health, CDC, and my colleagues at CHS. Thank you very much.
Thank you very much. Welcome the question from microphone number 2.
Thank you very much. It's great stuff. I'm George Rutherford from the University of California, San Francisco. In the Kenya AIDS Indicator Survey of 2012, we went back and looked at all the adolescents who were positive, and by doing some sort of complicated algorithm made up out of nothing, we thought that probably half of them had been infected perinatally, right? And I would say that, my concern about this, I completely give you the part about adherence and poor adherence is bad and all that. I would bet a large number of these kids have resistant virus because they're on nevirapine. And I would encourage you to go back and maybe look at what the third drug is, not what the NRTI background is, to see if you can figure out who should be switched out to a more active third drug.
Yes, thanks. That's taken. We do acknowledge that yes, we have adolescents who had vertical transmission, and I did actually mention that as a limitation in this assessment. This assessment was really focused on how we were going to use the data that we have from program implementation to derive strategies to improve adherence and viral suppression. But that's well taken.
Are there any interventions being planned after knowing the results of this cross-sectional studies?
Yes, correct. And some of the interventions are related to caregivers, so caregiver literacy, treatment literacy, and also ensuring that the adolescents have stable caregivers. We noted that quite a few of these adolescents did not have a stable caregiver because it would be either the parent has passed on and they have a grandparent who's also who depends on other people for their care. And so finding stable caregivers and in fact we found no difference whether it's a parent or a non-parent. So that's also helping us work within community structures to have stable caregivers for these adolescents to walk with them through their care.
So are there any plans to expand or extend it, revisit, clinic revisit instead of 2 months, postpone it to 6 months, or during the school holidays or Saturday, Sunday?
Absolutely. In fact, 96% of the adolescents had clinic revisits within a month or less. So this was something that was interesting, that it was a significant finding. And so we've differentiated the care for the adolescents to ensure that they have clinic visits on the weekends and also make those clinic visits specific for adolescent services. And we are obviously reviewing this prospectively to see the impact over time.
Okay, my next question. By knowing one's viral load, is that a good way or bad way to increase or decrease adherence? By knowing that my viral load is less, is undetectable, would that make the adolescent less adherence or more adherent because they're courage to continue?
I would probably say in Kenya we have the Operation 000 intervention that was presented earlier in this conference with very encouraging results that uses an asset-based approach to encouraging treatment adherence and achievement of viral suppression, which gives the adolescents confidence and actually are declared heroes once they achieve the zero viral load. And so they have christened the motto of zeros are heroes. And so this becomes an asset-based approach that it empowers the adolescent, gives them confidence that what they're doing is right, and they can encourage others to do the same.
Okay, thank you very much.
Thank you.
Now we come to the last presentation by Dr. Bernard Halfico. He's from the Ministry of Health in Namibia. In Namibia, his talk will be on progress towards HIV epidemic control, results from the Namibian population-based HIV impact assessment, PHIA.
All right, so thank you very much and good afternoon. I appreciate the chance given to me here to present this exciting result to you today. And I'm pleased to be here to represent the government of the Republic of Namibia and our partners, including PEPFAR, CDC, ICAP, among others. Namibia is a large country, as you can see on the slide there. And just for your orientation, I hope we have it. If you look down there, that's where we're located on the continent of Africa. Very small population of less than 3 million, but with relatively high incidence and prevalence of HIV, as informed by the UNAIDS 2012 data, as you can see. Since 2014, Namibia has been extensively scaling up its HIV services, and I hope we are on the same slide there. Since 2014, we've been scaling up our HIV services, and that includes promoting combination HIV prevention services, targeted testing, and rapid linkage to treatment. Also with rapid adoption of new ART guidelines, which include test and treating. Had a few innovations and decentralization of our clinical services and trying to make those systems sustainable, we believe has helped us quite a lot. The data in this table shows that the number of new HIV tests administered and cases identified and treatment initiated has increased rapidly in the last few years. It's just one of the NAMFIA team, and I hope you can recognize the stranger in the blue t-shirt there. The primary objective of NAMFIA actually to have a nationally representative sample of our population 15 to 64 years of age in order to estimate the national HIV incidence and the national and regional prevalence of the viral load suppression among those living with HIV. The secondary objective is to include national and subnational prevalence and the uptake of HIV testing and antiretroviral treatment, and pediatric prevalence at a national level, the last of which we're not presenting here today. Now, the survey design, which is rather technical. NAMFIA was designed as a two-stage cluster sample in order to achieve a nationally representative cross-sectional population-based surveys of households across the whole of Namibia. The survey was powered to measure national HIV incidence and subnational viral load suppression with fairly higher precision. So household members aged 0 to 64 years who slept in the same house the night before were considered eligible for inclusion. Household adults and adolescent questionnaires were used and included demographic, behavioral, and clinical information. Data collection was electronic and took place over the second half of last year. Now, to come to the lab testing is conducted at 4 levels. In the household, blood was drawn and HIV testing occurred based on the national algorithm, with results returned to the participant during the same visit. So at the satellite lab, all HIV positive samples were tested with HIV confirmatory test. Quality assurance testing also took place at the lab, and the DNA PCR was available for early infant diagnosis. In the central laboratory, viral load testing and HIV-1 avidity testing is conducted. Incidents based on the WHO criteria for recent HIV infection were also applied. And the antiretroviral we tested for in this survey is efavirenz, lopinavir, and nevirapine. These are the commonly used in our regimen back home. And finally, specialized laboratory testing for antiretroviral detection and now drug-resistant assays are being performed on those samples that tested positive. Qualitative ARV data were used in order to adjust first and second 90 indicators, allowing us to reflect both self-report and detectable ARV for those figures. In terms of statistical methods, the sample was weighted in order to adjust for factors such as selection probabilities, account for differences in non-responses, and take steps to achieve population representativeness. Now, the NAMFIA results. Almost 24,000 individuals participated in an NAMFIA survey, including about 7,000 children. The overall response rate was 67%, and you may have a question on that. We're able to answer. And was higher in women and children as compared to men, and I think this is not so much of a stranger. So the total national HIV prevalence in Namibia in 2017 was 12.6%. And prevalence among women was significantly higher than for men, as you can see in those graphs, and stayed at 15.7% compared to the 9.3% in the male equivalent. On the prevalence still, on the prevalence result distributed by 5-year age band and by sex. Here we have the prevalence as is shown on each slide, and I wouldn't want to dwell much on that. Just to say that HIV prevalence peaked at 30% among female aged 45 to 49 previously. And the prevalence was higher in women than men throughout the reproductive age. Here is the prevalence in region. You can see the right top, the Horn of Namibia has got the highest prevalence at 22.3%. This is the region that has got a higher tracking route, and it's bordering about 4 other countries in Southern Africa. So as you can see, there's a whole lot of movement. Unfortunately, this also happens to be the region that had the lowest circumcision rate in Namibia. So it's a whole lot of things that came together. Maybe to go back, I just want to point out that the two most less prevalent are those called Kunene in the west and Omaheke on the east. These are also the regions that traditionally do circumcision long before the advent of HIV. Now, to come to incidence, we here have or wish to present the ARV-adjusted incidence result with annual incidence of HIV among adults aged 15 to 49 years in Namibia, standing at 0.4%, and obviously higher again in females. And this corresponds to approximately 4,300 new adult cases annually. To come to the viral load suppression results, this data shows suppression among all adults living with HIV, regardless of their awareness of HIV status or their ART status. Overall, viral suppression was 77.7%. This was even higher in women at 81.7% compared to men with only 69.6%. In a 10-year age band, we see viral suppression was highest among older adults and lowest among young adults, with only half of the HIV-positive males aged 25 to 34 being suppressed. This was also the only age category with significant differences in viral suppression between women and men. Again, regionally or geographically, the regions with the highest HIV prevalence generally also has the highest proportion of individuals with virologically, who are virologically suppressed. We believe this is to do with maybe compliance, but we will talk more about. But also the regions that has got the lowest prevalence and incidence are also the ones that are not so well suppressed virologically. So there may be a bit of complications there. Progress to 99. We have results on the 99 cascades adjusted for detectable ARV to give more accurate results than self-reporting alone. As you can see, 86% of Namibian aged 15 to 64 living with HIV are aware of their status, with females, yet again, more likely to be aware than males. In this case, awareness was defined as self-reporting as HIV positive or having a detectable ARV medication in the blood. Among those who know their HIV status, over 96% were on ART. This is defined as a self-reporting current use of ART or having a detectable ARV in your blood. So among those, it shows that among those of the 90, it shows that 91.3% were virally suppressed. Here we see the 1999 cascade by 10-year age range from 15 to 64 years. Notably, only 72% of the adolescent and young adults 15 to 24 years who tested positive in a survey were aware of their positive status. This is much lower than for older adults, obviously, and linkage to ART initiation remains strong across the age category band. So in summary, ladies and gentlemen, I wish to say that in summary, key findings include, number one, higher total adult prevalence of 12.6% in the country, a wide geographic variations, incidence coming down by about 50% compared to the 2012 modeled estimate. And overall, viral load suppression was 77%. The 1999 cascade in Namibia is close to full achievement of UNAID target, with 86% of the people being aware. And of those, 96% are on ART. And of those, 91% with viral suppression. I just wish you are making the distinction between this last 91% and the overall population base of 77% viral suppression. The data also show that once diagnosis, over 90% of both male and female Namibian living with HIV started on HIV. And over 90% of these are actually virally suppressed. So, of concern, obviously, is the much higher proportion of adolescents and young adults who were not aware of the HIV positive status. I think I went a little bit too fast. In conclusion, therefore, what does this mean to Namibia and perhaps to the world at large? Certainly, we can be happy to have achieved an international milestone by already exceeding the 2020 UNAID goal, for the third goal at least. I'm excited by the fact that women in Namibia have already reached all the 1990. This has very positive implication for sexual and vertical transmission, in addition to women's health and survival in general. Even though women have higher prevalence and incidence than men, their outcomes are also much better. There are areas of concern that still exist, though, especially in young men who don't know their status. We need to accelerate our strategies in these areas to reach our goal of true HIV epidemic control. Ultimately, this data from NAMFIA shows the historic success that our national HIV response has achieved so far. At the same time, this will help direct our programming to places and people where it needs to be in order to truly end AIDS for Namibia. I would like to thank and acknowledge our partners, and I hope I can put them so I flashed them, but mostly PEPFAR, CDC, UNH, other agency, and most importantly, the ground or field workers who were up there capturing the data. I thank you.
Congratulations with Namibia in reaching the 1999 targets. Do you think that this will make your policy makers somewhat relaxed, complacent, and just we reached that already? We don't have to do much more about this. This is what we are afraid in Thailand. This is what I'm asking.
No time to relax, and no place for complacency. This is a clear indication that if we persevere, if we persist, if we keep pushing forward, we will reach our objective. And I think this put an extra spike of energy in our program, especially that we have the population-based data, so that will motivate us much more.
Thank you. Yeah. Question number 2.
Minister, thank you very much for a very exciting presentation. I'm Peter Godfrey-Fawcett from UNAIDS in Geneva. I think you were expecting the question, but I'd just like a little bit of understanding of the nearly 40% of men that you aimed to detect in your sample who weren't surveyed. Because I think you said that 62% or so of the sample was achieved. So I just wonder whether the people who were not sampled were really the same as the people who were sampled.
Well, I forgot actually to say that I have technical people who were right in the field here. They will help me out on some of the technical questions. But if I get your question and you needed to speak a little bit slower, are you referring to the 77 population result, or did I miss what you said? Yeah, just a bit slowly, please.
The participation in the survey, you had a sampling process, and you said that some of the people that you aimed to sample, you didn't actually collect a sample from. I think you said that you collected about 60% of the samples you expected from men and about 70%, I can't remember the figures exactly, from women. So you missed some people in the survey, and I just wonder if they're the same, the people you missed as the people you didn't miss, whether there was a sampling bias.
Well, I may have to ask maybe Tetu or somebody here to just briefly explain this before I say something political. Yeah, Tetu or somebody can quickly and help answer that question. It's unfortunately highly technical. Tetu or Eric? Yeah, Eric is here.
Yeah, the response rate was a little lower in the men. Fortunately, we were able to account for that with weighting of the sample. And so we feel good about where the results are. Confidence intervals, you'll see sometimes are a little more narrow in women because of that. It falls right around in the middle of the range for the FIAs that have been performed across African countries. I think we saw Cameroon's results released earlier this week. They had an exceptionally high response rate, but ours are higher than several of the others.
Thank you, Eric.
Okay. One more.
Try to be as political as possible when you ask the question, and I will be finding it very easy to answer.
Thank you very much, Honourable Minister. Richard from Botswana. Not associated with Zambezi, except that we are very close also with the Chobe. Honourable Minister, I'm not sure whether I got the figures right. The prevalence, was it 8 in the last survey, and therefore now it's 12? And if it's so, that could be maybe an increase in the prevalence, but the incidence is from 0.8, a decrease to a 0.4. Any association between the increase in the prevalence and therefore the good news that there's a decrease in the incidence, if I got the figures right? If not, can I just get the figures right, especially the prevalence figures between the previous and the current? Thank you.
Can someone maybe help here with the figures? Yeah, well, prevalence meaning people that you have identified, and almost all of them on treatment. So I wouldn't really be worried having higher prevalence of people, meaning we are catching them up, we're putting them on treatment. And I think it's corresponding nicely inversely with a dropping in incidence. That means new people, new infections are going down, whereas our data are accumulating a higher number of people that we call the prevalence. That's the way I try to understand it. So I wouldn't worry much on the side of the prevalence if we are cutting down on incidence, because it means you have those people basically on treatment. I would have worried about the viral load level and suppression, because that is an data of actually a catalyst for transmission. That's how you transmit the virus, unless maybe I missed something out of your question. Okay. And you particularly referred to Zambezi, the Horn of Namibia. That has been always the trouble spot, and that's why we want to focus more on that one, to bring down the incidence and hopefully affecting the prevalence one way or another. But as I said, if people are on treatment, my interpretation is that transmission will be low, even if the number may be high.
Okay, thank you very much. So, I and my co-chair would like to thank the speakers and also the audience here that we learned today that we have to do things fast, test it fast, treat it fast, and then to do whatever prevention that's possible fast in order to end it. Yeah. Thank you very much, everyone.